we are now here present with the whole faculty, and unfortunately, no questions yet in the stream. Francesco, I see that you have a question. Can you please go ahead?
Just a sec. Yeah, I think that one of the most difficult conditions is to identify coarctation of aorta, especially in the third trimester. We have a lot cases, so a lot of mother which were referred with a lot of anxiety because, of course, when someone notice a discrepancy between the left and the right part of the and the left and the right part of the heart, they just refer straight away and scare the patient. So there are many studies which do not have meaningful conclusions. So do you think it's more accurate to rely on the ratio between the aorta and pulmonary artery, the three-vessel view, or just do a direct measurement of the sagittal view of the aorta, and just rely on the published charts?
I presume that question is for Sally-Ann Kleur. Sally, do you want to comment on that?
Well, if you look at the markers, and there are lots of markers for coarctation, and you look at their predictive values, you'll see that all of them have a significant value. However, that doesn't really help us because they're all not specific. So if you take several markers together, it has been shown that increases your sensitivity. So the more features you have, the higher your chance. I think it's also very helpful when you have additional features. And that came out of our the Cahal study, where if you have additional hypoplastic arch or you have a ventricular septal defect, that is helpful. I think it's very important to measure not only the valves of the pulmonary and the aortic valve, but also the size of the ascending aorta, and to look at your aortic arch anatomy. Features that are helpful are indeed an increased space between your second and your third branch, and a ratio between that space and the aortic arch can help you to identify your coarctations better. You can also see diastolic prograde flow in the distal arch, which can be helpful, and also look for your the 3 sign or the posterior shelf of coarctation. And there are new ideas. One of the ideas is that because there is less flow into your left ventricle and the left ventricle is small, it tends to have less good diastolic function. And so you can look with speckle tracking and looking at strain. And if you have strain abnormalities, that can additionally help you in identification of your coarctation. And we also now have the option to do MRI studies on our fetuses. And if you do an MRI in a coarctation, you can look at the anatomy of your aortic arch, which is certainly already been described by the group in London. And you can also look, if you have the option to do 4D flow, you can look at the flow patterns in the aortic arch. And one of the things that has been identified as a marker for a true coarctation is if you see that there is some flow of the blood coming out of the duct going retrogradely up into the subclavian artery. So there are a lot of things you can look for, and you must have a high index of suspicion and look for many markers. Oh, and what I didn't mention was also the bidirectional flow across the foramen of Filey, which is also a very good marker. And if you have a VSD and you have predominantly left to right shunting across your VSD, that is also helpful.
Thank you. Thank you so much. Very informative.
May I have an additional comment, Francesco, to the very important thing that Sally-Ann mentioned? All the things that Sally-Ann said, they are very much true, and I fully agree with that. The only problem is that a lot of studies compared those parameters to normal fetuses. And if you have in your fetal medicine clinic, you have a referral for left-right discrepancy, a lot of these parameters do not work so well anymore. And that I think remains a problem in cases that are suspected for coarctation. For instance, I just finished a study on speckle tracking, and then not published yet, so these are unpublished results. We are writing it up at the moment. If you compare speckle tracking in cases which are already sent in for left-right discrepancy, and you divide those groups in the cases that had an operation in the first life for coax and those that did not need it, then the speckle tracking was not differentiating anymore. And that is the big problem with screening compared to diagnosing in the fetal medicine unit. A lot of those parameters are not working that well anymore, and we are still faced with a substantial amount of cases that we have to admit to the ICU, and we have to see after duct closure if there will be a cohort or not. And I think we still should accept a small amount of that cases, just not to miss the coarctation cases. And I hope that future technologies such as MRI will help us, but it is a difficult decision if a case has left-right discrepancy, not to put those babies on the ICU. That still remains a problem to be very sure of, and maybe that influences the decision of primarily start your prostaglandins, but to send those babies back to a unit without pediatric cardiology service, I think this is still a difficult thing to predict.
Indeed. Thank you for that, Monique. I think that the problem that you describe here is very real, and I think the problem is that when we see left to right disproportion, we have an underfilled left ventricle. So one must think about all the causes of underfilling of that left ventricle. So start with the foramen ovale and examine the foramen ovale well, because certainly in the last trimester, it might be that there is mild restriction of the foramen ovale and nothing else. And so, you have to do a good interrogation of the fetal heart. I think there was a question from one of the other participants.
I absolutely agree with both of you, because the diagnosis of coarctation is a problem everywhere. Even after birth on the first day, sometimes we may find a shelf, you may find a sort of reduced flow, you may be tempted to start prostaglandin, but the wise decision would be to wait and see if manifests when the duct constricts and then start, then you know that this baby is going to go for surgery. Otherwise, it will be ridiculous to just sort of assume that there is coarctation with an open duct and send for an unnecessary surgery, and that won't be a good practice. So I think it's good to suspect, because missing a coarctation is far more dangerous than suspecting it, because we can always put a red flag up there, and the neonatologist is aware of the fact that this baby could possibly have a duct-dependent circulation. That makes the whole team more wary about the fact that this is not a routine neonatal admission. So I think from that perspective, left-right asymmetry or disproportion and a smallish aorta, smallish isthmus, all the parameters which Sally Ann mentioned will be of value, because to put that baby into a position where, okay, you're not yet ready, safe to go out to your mom's, just we want to watch you for some more time, that's a pretty wise decision clinically.
I think
Simon has a comment.
Oh, sorry.
Simon has a question. We don't hear you, Simon.
Can you hear me now?
Yes.
Sorry about that. Really just a comment to support what Sally Ann and Balo made. And I think it's more a broader comment for knowing that there's an audience of quite different levels of experience, from beginners to very advanced imaging, attending the course. Yesterday, we spoke about spina bifida being a condition in which there were 15 to 20 markers reported. And I said yesterday, tell me of a condition in fetal imaging and prenatal diagnosis that requires 15 to 20 markers to make a diagnosis. I actually forgot about coarctation, and because actually coarctation is a condition which, in fact, when I talk about markers, it has got more measurements described than any other condition in prenatal imaging. There are 25 specific measurements, either unique measurements or ratios of measurements, to try and identify, reduce the false positive and false negative rates with coarctation. It's a standout. It's an extremely number one common condition. And it's the anomaly, the fetal cardiac anomaly with the highest false negative and the highest false positive rate in diagnosis. I really worry about the false positive rate because that's probably the more frequent one we see prenatally, and the anxiety we call for so many patients, telling them that there's a problem because we don't know what's going to happen, the duct, once it closes, and what the elasticity of the aorta is going to take and whether it becomes problematic or not. And I worry really about that group where we overcall. I think particularly the third trimester, more than the second trimester, more than the first trimester, is where this problem exists. And of course, as Balo said, you worry about the false negative diagnosis as well. And we sort of rely on the pediatric cardiologist postnatally with femoral pulse examination and so on to pick them up. But even then, Balo and Sally-Ann, I'm sure you're familiar with those who escape the postnatal examination and come back in, particularly the ones with VSDs. The VSDs close and the babies come back in blue. So it's just a broad comment. It's extremely challenging, and with a high false positive and false negative diagnosis. And I don't know if either of you have a particular preferred or best measurement that you feel is of value in clinical practice going forward. We have a thing of serial measurement of Z scores of the isthmus on the 3-vessel tracheal view, but I don't know. What do you guys do?
Sally, you start first.
Well, I try to look at most of the things that are advised. I like to measure on the 3-vessel and tracheal view the isthmus to the ductal ratio. But I also do try to get also a sagittal view of the arch so that I can also see in another direction, another plane, the isthmus. And a small isthmus is a strong indicator. Of course, we must also realize you can never be 100% correct. You can never predict it 100% prenatally, because there are some cases where the aortic arch is completely normal. You see nothing, but there is extension of ductal tissue into the aorta, so that those babies will surprise you because they will have a coarctation when the ductal tissue starts to contract. So you cannot be 100% correct. But you can try and be as close to that as possible.
Absolutely. So, what Sally was saying is the two theories for coact, the ductal theory versus the hemodynamic theory. Most of the fetal diagnosis rests on the hemodynamic theory, that there is less flow, so the aorta is small. And we do use the serial reduction, the Z scores of the isthmus or the isthmus duct ratio and isthmus shelf. Sometimes you may even get a flow turbulence, but these are some of the things which are published in as predictive markers, specific markers for coact. But then the other aspect, recently we had a case where actually the duct was located above, between the subclavian and the common carotid, and the coarctation actually happened there, while in the actual area of the duct, when it constricted, coact did not happen. So the ductal theory also plays a pretty important role, which, and as Sally said, you don't know which patient actually with a reasonably normal looking or good sized aorta in fetal imaging turns out to be coact after birth. So I think the only thing we can do is, as Simon, we will have to deal with some anxious parents. But the good thing about our job being a pediatric cardiologist is that we can always say that we did some magic. So the coact which we picked up prenatally, good news. Yeah, so we can always tell them that we did some magic, some things we did, and so there is no coact. So most of the people, when they say your baby, the baby won't require surgery, I mean, they will generally forget the anxiety, because good news always takes away the anxiety and the bad news. So most of the time we get away, but then the third trimester anxiety will be a problem to deal with.
If I may comment on that, as an obstetrician, as an FMF, I would say the only thing what is really needed is to really prepare parents on both scenarios, because they are so focused on the baby possibly needing an operation that sometimes in the cases where there is after duct closure an open arch, and no coarctation present, that they cannot adjust to that scenario. And I think there is a very important task for the obstetric team to also prepare parents on that scenario. There is a question from the audience, Anna Grebinishenko. I hope I pronounced it well. Her question is, how often do you see aortic coarctation without aortic arch hypoplasia?
I don't know the exact figures. Does she mean in general or does she mean prenatally?
I think prenatally.
Okay, so I think that when we have hypoplasia of the aortic arch, we generally see it. And so these are the cases that we pick up much better than the ones that just have a local coarctation. They're the most difficult ones to pick up. And I showed you in my talk that in the Amsterdam Leiden area, when we reviewed the figures recently, it was about 45% detection of that particular type. But that was comparing the prenatal cases with the postnatal cases.
Well, if I may comment, I think that whereas we are in quite of a good place with the prenatal diagnosis of transposition of the great arteries, as Monique showed, at least Dutch data, I really think that coarctation will remain a problem because sometimes only late in pregnancy there are ultrasound markers of this pathology, and there are many countries where a third trimester scan is not performed. Did you see a change in, let's say, in presentation of children coming to your unit in a poor condition with less related to transposition and relatively more related to a not seen coarctation?
Yes, I think we do have that. And just because it's so difficult, we are detecting up to 80% of our transpositions and only 45% of our isolated coarctations. And yeah, they're both relatively common disorders, but the coarctation is more commonly seen than transposition.
Do you also think, Sally-Ann, that because, for instance, univentricular heart defects and we have a detection rate of around 100% in our country, transposition now over 80% of our country, that let's say local hospitals maybe do tend not to think of a heart defect in babies that are brought in that level of hospitals? That the diagnosis phase, that could be a drawback of good prenatal diagnosis, that the children, the infants that are missed in screening get a later diagnosis because local doctors do not think of the possibility of a heart defect anymore. Is that your experience as a pediatric cardiologist or not?
Well, it is my experience when I have had a low suspicion of a coarctation. And when it was requested by the mom to rather not have the delivery in the academic hospital, that when I communicated with the pediatrician that would then be responsible for seeing that baby postnatally, they decided not to do it because they were anxious but what if it really is a coarctation? So there's a lot of anxiety. And also, if you're not seeing these things regularly, you lose your finesse. And you lose your automatic responses. And so I think, although we do a lot of good with our prenatal diagnosis, it also means that the skills of people who are not seeing these cases regularly are affected. I see that Simon has a question again.
We'll have two questions. One for Balu, if I could ask. With regard to pulmonary stenosis and seeing pulmonary valve regurgitation is something we're seeing more and more with these as the technology improves. If you could maybe pass comment on the significance of evaluation and technically how to evaluate pulmonary valve regurgitation in the setting of pulmonary stenosis and what the significance of that is in relation to Noonan syndrome. Mm-hmm. And the second question was, Sally-Ann, with regard to serial monitoring of coarctation increasingly as those with a small left ventricle and significant ratio difference between tricuspid and mitral valve, we're seeing reversal of flow along the transverse aortic arch. It scares the hell out of us as prenatal diagnosticians because we think we're looking at a duct-dependent lesion. And should we be worrying maybe less about reversal of flow in the transverse arch in coarc as we serially monitor these into the third trimester? So maybe Bala wants to answer his first question.
Thank you, Simon. I think I did not put the dysplastic pulmonary valve in my talk because the most cases of these tends to have a reasonably good size RV. Sometimes they may even have a dilated RV because of the pulmonary regurgitation. The valve tissue is abnormal here. They're thick, they're dysplastic, so it's a combination of stenosis and regurgitation, much like the bicuspid aortic valve, which may have a combination of AS and AR. Most of these cases may not need intervention because the PS is often, the stenosis is overestimated because of the regurgitation, so that the next jet, the more blood goes through. So we do a postnatal echo, and if the stenosis and regurgitation are okay, most of the time, most patients may not need a surgical intervention. Follow-up is all that's required. Severe cases of pulmonary regurgitation, you need to watch the right ventricle because that can get volume overloaded and that could be a problem. And then there is theoretically the chance that it can set in another regurgitation in the form of TR, and that can be a problem. So that is rare. So that can sometimes occur in the cases of tetralogy absent pulmonary valve. And there is also an entity where there is a TOF absent pulmonary valve with a restrictive VSD.
Yeah.
So these are the situations where you can have real problems with the right ventricle. With the right ventricle can go into failure, potentially leading to high drops. So those are the red flags for this particular condition. As regards Noonan's, very often there is this association of pulmonic stenosis with Noonan's, especially if there is a stenosis of the branch pulmonary arteries as well, which can often coexist. In fact, in the case which I showed, the right pulmonary artery was smaller. And if you have such situations, we need to do the test for Noonan's. That would be perhaps the most important extracardiac evaluation we would do in these cases. So the sum up answer would be the PS plus PR would be a problem if the ventricular septum is intact, or if the VSD is restrictive, leading to ballooning and dilatation of the right ventricle. So that's a problem. So then we need to watch that. And then, of course, the genetic testing needs to be done. But most of the cases of dysplastic valve with PS and PR tends to have a fair prognosis from the cardiac point of view, and most of them may not need intervention.
Thanks, Bala.
So to come back to your question, Simon, about the retrograde flow in the aortic arch. I think when you are evaluating a heart, you must always think about the hemodynamics of what you're seeing. Why is it happening? So if you have a situation where you have more blood coming from your duct than what you are actually having prograde in your aorta, so that some of the ductal flow is now going retrogradely in your aortic arch, I think there are three things that you need to consider. Do we have increased pressure in our pulmonary arteries? So have we got a situation of pulmonary hypertension? You need to be sure that you do not have a baby that is not growing adequately, because we know that intrauterine growth retardation with reduction of your cerebral resistance to increase cerebral blood flow, you can also get retrograde flow in your aortic arch in that situation. Or do we have a situation where the flow from the left ventricle is inadequate, and so that the duct has to fill up? So remember that it's not only coarctation that can give you those signs, it can be other lesions as well. And so you have to really have examined your baby properly.
And how do we assess pulmonary hypertension in the fetus?
Well, I think that is also difficult. I think that one has to look at the right ventricle. We have to look at the foramen ovale, and also make sure that we have a normal heart, because if you happen to have transposition, that could be an interesting marker where you actually would then have retrograde flow in your duct and not in your aortic arch.
Yeah. Thanks, Sally.
What about Dopplers of the pulmonary veins? Could that be of use in this case or not?
in the case of pulmonary hypertension. Yes, if you have increased flow in your pulmonary veins for some reason, that is unusual, and certainly that's also one of the things that is a marker of pulmonary hypertension in transposition, because they have a higher peak velocity in the pulmonary veins in some cases associated with pulmonary hypertension.
Yeah, and also the presence of retrograde A wave, prominent retrograde A wave in the PA. That could be a feature of restrictive foramen ovale. And we have also noticed that transpositions which have restrictive foramen ovale tend to have slightly higher pulmonary hypertension in the postoperative period compared to some of them which do not have. So in utero constriction of both the ductus arteriosus and foramen ovale in many of these settings can have an effect on pulmonary circulation and can potentially reflect as pulmonary hypertension after birth. One of the very bad cases of pulmonary hypertension which I have encountered is the prenatal constriction of ductus arteriosus, which can be a devastating complication, leads to severe pulmonary hypertension, pulmonary hemorrhage, and pulmonary edema, and this is sometimes can be very difficult to manage as well. So I think the physiology of the shunts, both the foramen ovale and ductus, requires special attention in all cases.
I have a final question, in actual fact, to Céliane, Balu, and also Monique, because you alluded in your lectures, the two pediatric cardiologists, to fetal interventions to relieve obstructions right and left. I remember that in the past, this was still a little bit of a taboo, and I remember that Lindsay Allen many years ago was quite, let's say, pessimistic about these interventions. Whereas you reported the cases from Linz, which is indeed a success story. So I would like to know from the three of you, what is your view on the future of fetal cardiac interventions in these conditions?
Who should start? I think that it's very important, and what the future is going to show us is which patients are the correct candidates to do the procedures on. I think that's where we're going to be going, because certainly we've seen that in aortic stenosis, where we intervened once the left ventricle is no longer salvageable, that you don't prevent a univentricular outcome. And I think that is the challenge. The challenge is to be able to determine which fetus is a candidate for the intervention. I think that's our challenge, and what we hope to be able to do better in the future.
I completely agree with Céliane. I think especially for the right heart interventions, which are technically more challenging than the aortic intervention. It's perhaps very important to define, and if the RV is already small, the tricuspid valve is small, you opening up the pulmonary valve alone may not solve your problem. There is some encouraging data from Gerald Tulser's unit that sometimes there's a slightly higher incidence of biventricular hearts. The one advantage with the right heart is that it is a bit more yielding, and it's a bit more resistant. It's that, in fact, it allows you more options after birth, because we can do what is called a 1.5 ventricle repair, where we direct one of the veins to the right heart and then to the pulmonary artery, and the rest you do a procedure called bidirectional Glenn shunt. And this may be a better option than a complete single ventricle. So that's where potentially a good candidate for what some of these may end up with a better heart, if not single ventricle, at least 1.5 ventricle after birth. So I agree with Céliane that case selection is perhaps and a better armamentarium and better criteria for selecting cases. That should be what we should be working on right now.
Monique, do you want to comment?
Yeah, I think gestational age is very important in fetal cardiac interventions. And in my experience, aortic valvuloplasty below, let's say, 23 weeks, the myocardium of those very young hearts is so vulnerable for the high pressure the aortic stenosis creates, that the development afterwards is almost never successful, even after a successful opening of the aortic valve. And that you see also from Austria, they don't do that many below 24, 23 weeks. And if you do them later, the optimal gestational age, around 30 weeks, I think there is an opportunity that a fetus really benefits. And if you go even later, then it is also very much depending on the strategy of the postnatal care, because in our unit, if a baby comes in after birth with a very large left ventricle, then usually our team can make that biventricular. Only the ICU period is a little bit longer, but with a hybrid approach. So there's also a category of infants that can get a biventricular repair that maybe in other units would have had a fetal intervention. Do you understand what I mean? So there has never have been an RCT, so it is very, very difficult to identify the fetus that really benefit from a fetal intervention. I think the future goes to atrial septum interventions, but we are running over time now.
Okay. Yes, indeed. So we shouldn't really run into the lunchtime of our delegates. I take the opportunity to thank you all for the wonderful presentation this morning, and also to thank our sponsors, GE, that made this possible. And we will see each other in 40 minutes, well, in 39 minutes from now. Thank you very much, and have a nice lunch.